Chapter 11, Assessing the Eyes. The eyes are a complex organ. Sight occurs when the eyes and brain work together to detect, translate, and interpret incoming visual spectrum electromagnetic radiation. This is very similar to the ears, where the ears detect sound, translate sound through the cochlear, and then interpret sound in their brain to determine what's being said. So the eyes do the same exact thing. There are external as well as internal structures of the eyes, and there are cranial nerves associated with the eyes. And again, we're going to revisit the cranial nerves when we touch upon chapter 11, the neurological chapter. But understand there's 3 specific nerves that are associated with the eyes. There are extraocular as well as intraocular structures, and the intraocular structures we're going to be assessing by using the ophthalmoscope. And again, just like with the otoscope, you're not required to purchase an ophthalmoscope. However, you should understand what an ophthalmoscope looks like and how to correctly use an ophthalmoscope. So, and there are also diagnostics such as the comprehensive diagnostic in which the eye is dilated to help us look at the retina as well as internal structures. And there's also a pressure gauge used to measure the intraocular pressure of the vitreous. So go back to your anatomy and physiology book, go back and reflect on the anatomy of the eye. And identify each key component associated with the eye, such as the function and features of the external structures of the eye, where the canthuses are located, the cornea, the iris, the pupils, everything, all of those minute structures that are associated with the eye. What is the thin membrane covering the front of the eye and inner eyelids called? If you said conjunctiva, you're correct. And that is just simply a thin membrane covering the front of the eye as well as the inner eyelids. It produces mucus that will help lubricate the eye and permits the movement of the eyeball. The lacrimal glands, which are located on the outer portions of the eyes, right under your eyebrow, creates lubricant, creates tears that actually are transferred down the lacrimal canal and into your eye, and it helps you also helps to add moisture to the eyeball to allow the eye to prevent from becoming dry. When collecting patient's health history, you want to ask about eye problems or eye diseases, more so personal eye diseases, eye problems, cataracts, glaucoma, macular degeneration, if they've ever had any eye surgeries or any surgeries that help to reshape the cornea that corrects vision, as well as astigmatism. Family history is also extremely important to ask about. Some of these complications, cataracts, glaucoma, macular degeneration, are hereditary, so it's important to determine if there is a family history. Cataracts is simply a clouding of the lens. Glaucoma is increase in the vitreous substance that's located behind the eye that can impact vision and visual impairment. Macular degeneration is more so degeneration of the macula, and usually you could see or identify degeneration by using your ophthalmoscope to see if there's any areas of gray or blurred areas right where the macula is located in the back of the eye. Family history is located right there. You also want to ask about their last eye exam. You want to ask about like what's currently going on. Have they noticed any changes with their vision, blurriness? Are they finding that they're squinting more when they're reading? What might have been easy for them to read like last year is becoming more and more difficult. Are there any spots, blurry vision, any changes in their visual field or loss of vision in their visual field? You want to ask if they wear glasses, how long have they been wearing glasses, when did they first get their prescription, if they're not wearing glasses, are they wearing contacts? Sometimes it's not very obvious to the person. And if they have difficulty reading, and what distance do they have difficulty reading? You want to ask them about their eyes. You want to ask if they've had any drainage or redness, any irritation or itching, changes in their vision, night vision. What is that like? When they're driving, is there a glare? Do they have any white specks or dark specks or areas of flashing light when they're seeing? And this can also have something to do with their cranial nerves. So during a health history, the patient states that they've been wearing contact lenses for the past 5 years. What questions should you ask the patient? Select all that apply. Do they wear contacts? Are the contacts soft or hard? Do they sleep with their contacts? Do they have any problems with wearing contact lenses? Do they experience redness or irritation? If you've answered B, C, D, and E, that's correct, because all of those questions are more focused and should be asked about the patient's experience wearing contact lenses. You already know that they're wearing contact lenses, so you don't really have to ask them that question again. It's like a little bit of a trick question for you. So the sequence of the assessment includes inspection and really assessment as well as palpation. Inspect the eye, look at the eye, look for symmetry of the eye, make sure you have good lighting, look for any changes, look at the features in and around the external part of their eye. Visual acuity will require a Snellen chart. There's also another chart that you can use for color blindness, central vision, as well as peripheral vision. There's peripheral visual field assessment, ocular mobility. You can use an H, a star, to assess how well their eyes move. Accommodation is, having them focus on an object and then using a light source to assess for pupil dilation and consensual relation. So inspecting the eye, you want to inspect the eyelids, observe the eyelids, have them open and close their eyelids, make sure there's symmetry. When they close their eyes, there's a complete closure of the eyes. Look at the hair, look at their eyelashes, more specifically, not necessarily their eyebrows, but their eyelashes, because their eyelashes are what's going to catch any foreign like objects, lint, dust. Look at the distribution of their eyelashes, identify any how the distribution looks, as well as if there's any drainage. You want to look at their eyebrows for asymmetry or symmetry rather, symmetrical hair, skin, just in and around everything that has to do with their eyes, because the eyebrows also collect, any dust. So that's just like another protective feature of the eyes. You want to look at the eyeball, really pull down their eyelids and inspect their cornea, inspect their lens. Sometimes when somebody has cataracts, you can actually see clouding or cloudiness of their lens. It's more of a white kind of film. Assess the sclera. The sclera is the whiteness of the eyes. Assess for color as well as the surface area. And then you want to wear gloves and pull down their eyelids to assess their conjunctiva. You want to make sure that it's nice and pink and moist. There's no evidence of excessive drainage. There are no masses, no lesions noted anywhere. You want to inspect the lacrimal duct, by palpating the top. Sometimes if there's a clogged duct, you can feel a little nodule. Identify if there's any excessive swelling or tearing when you're palpating. You want to assess the palpable fissures, which are the distance of the upper lid to the lower lid for symmetry. Again, when they close their eyes, there should be symmetry. There shouldn't be any openings anywhere, and the eyelashes should touch completely. You also want to look at their eyes and see how their eyes move, identifying any involuntary eye movement. So again, normal findings include the following: symmetry, eyelids completely closed, there's no drainage, there's equal distribution of the lashes, pupils are equal in size when the light is shined on your eye pupils, the sclera should be white, the conjunctiva should be pink and moist, and there should be really no abnormal movements of the eye or the eyeballs. And these are just some examples of abnormal findings, pretty much opposite of what we talked about. I do want you to know the terminology that is located on the right side of this slide. So look those terms up. They should be throughout your book chapter and chapter 11 to help you understand what each of those terms mean. Ectropion, entropion, exophthalmos, Herodilum, icterius, poptosis. Assessing for visual acuity, you will be using a Snellen chart, such as that. And the Snellen chart is simply to determine if the patient is able to see. And if a patient is not able, they're not literate, there are other charts that can be used. But you're really measuring visual acuity by having the patient stand about 20 feet away, having them cover one eye. If they're wearing glasses, make sure they keep their glasses on, because they're standing 20 feet away and they're still not able to read with their glasses. It just might mean they need a new prescription or an updated prescription of their glasses. And you want to start at the top and work your way down. Patient reads the row from left to right. You're going to ask the patient to read each line until they are not able to identify one or two letters in the line correctly. And then you want to repeat it on the opposite eye. And then you want to repeat it with both eyes uncovered. And then document the last line that was correctly read. And normally patients should read, they should have 20 by 20 normal distant visual acuity. They should read at 20 feet what normally should be read at 20 feet. The higher the denominator, which is that bottom number, the poorer distant visual acuity is. Myopia is simply distant objects appear blurred because the visual image becomes focused in front of the retina instead of on the retina, and myopia is really nearsightedness. Hyperopia is farsightedness. Hyperopia is they're able to see at a very far distance, but anything that's very close to them, they have a hard time distinguishing. Presbyopia is visual impairment with the older population. And then legal blindness is usually 20/200. You're inspecting a patient's eyes and note bilateral everted lower lids. What is the name of this abnormal finding? If you said B, ectropion, you are correct. That's an everted lid. Assessing for color blindness. This is to distinguish the ability, rather, to distinguish colors. And that is an example of a a tool that can be used to determine. And if you are colorblind, you are not able to distinguish that there's a 35 in the middle with the red 3 surrounded by the green dots. Patients who are unable to identify the colors or don't see the colors green or red can indicate color blindness. Okay. Another test is to assess for central vision, and this is actually a test used to determine if somebody has macular degeneration or has some type of central vision impairment. With macular degeneration, a lot of times there's an impairment in the center part of their vision, where everything else around it, peripheral, is more clear. And with this, there's that type of a diagram. There are other diagrams, and you're asking the patient to look in the center to determine if there are any distorted or broken or blurry lines in the middle. And you just repeat, one eye and then repeat on the other. And there should not be any lines that look distorted. Any lines that look distorted, broken, or blurred can indicate macular degeneration. The confrontation test is more assessing the peripheral vision. It's like the patient's head is in a fishbowl, and you're asking them to identify when they see the peripheral field in view. So you're asking the patient to face you, cover your right eye. The patient covers his or her or their left eye with a hand, and then you're instructing the patient to look directly at you with their uncovered eye. As you're having them do that, you're moving the fingers of your left hand into the field of vision from 4 angles, and you're asking them when they see the vision, or the fingers that you're pointing to. And the time that they say, "Now I see it," should kind of match up with when you see it, unless you, of course, have peripheral visual field impairment. So here's just a picture of what this should look like. Okay. The patient sees your fingers at the same time you do and correctly states the number of fingers they see. And you just repeat it from one side to the other. An abnormal finding is when they don't see your fingers. And if that's the case, there might be some blind spots that are related to that particular eye. And then further eye assessments need to be done. Testing for ocular motility, there's a couple of different tests for this, but the more common one is having them draw an H or a star. 5 points to see, number 1, if they're able to, with both eyes, follow your fingers. That talks to us about, how well their extraocular muscles are functioning, as well as their cranial nerves being able to follow the focus. So you can use any object. You can use a pen light, your finger. You're asking them not to move their head, but only their eyes to follow your finger. And you're assessing again, the extraocular muscles by having them raise their eyes up, raise them down, raise them side to side, and then also you're doing an angle to identify the diagonal portions of their eye. Normal findings of these six cardinal directions is that there's a normal pattern of movement. You're assessing a patient's central vision. How would you go about assessing this? Which of the following tests would you use? If you said B, you're correct. The next test is to determine convergence and accommodation. And this is where you're having the patient sit in front of you or stand in front of you. You're placing an object close to their eye and moving it away, more so towards their nose, and then identifying how their eyes move, what their pupils are doing. Your pupils focus when they constrict. So you can hold a pen light, you can hold your finger, and then you're instructing the patient to focus on your finger object for 30 seconds, and then just follow your finger or your object as you move it close and away from their nose. And so that's an example of what that test looks like. And again, the muscles should converge. Each eye should really match up to what the other eye is doing. And the eye pupils should constrict as the object gets closer. As it gets away, the pupils slightly dilate. And these are normal and abnormal findings. Inspecting the pupil size and consensual response is with the use of a pen light, in which you're taking the pen light and you're shining it on the eye. You're covering one eye, you're shining it on the eye, and you're seeing how the pupil responds. And pupils will naturally constrict to protect the retina when there's a bright light shining on it. So naturally, when you shine a light, it could be your pen light, it could be the ophthalmoscope, the pupil should constrict, and it should match up. So when you're testing the other eye, there should be equal response. Consensual response is when you're shining the light on the pupil, you have the eye covered, and then you're removing your hand from the other eye and you're looking to see what is happening with the other eye. Consensual response is if this pupil is constricted, when you take your hand away, the other pupil should start to also constrict. It's a consensual response to that bright light. Both of your eyes, no matter what eye is getting more of the light source, they should both do the same thing. One pupil should not be constricted, the other should not be just dilated. They should always constrict together or dilate together. And this all has to do with cranial nerve number 3. 3 is what helps with the dilation and constriction of the pupils. And normally the constriction should be about 2 millimeters and dilation should be about 8. What technique assesses for weakness or problems with the ocular muscles? If you said C, you're correct. It's the ocular motility test. It's the H or the STAR test. You're inspecting the eyes of a 56-year-old man. He reports that he's been seeing specks in his eyes upon waking every morning, which is not a normal finding. If you said B, you are correct. Assessing with the ophthalmoscope. Now, I did not expect you to purchase an otoscope. I didn't expect you to purchase an ophthalmoscope. It could be a little pricey, but if you have access to one, please use it. Please practice with it. Please make sure you understand how to use it. But you should, in general, understand what it is, how it looks like, and exactly how to correctly use an ophthalmoscope, and what, when you're using it, features of the retina you are looking at. So it's important to obviously turn the ophthalmoscope on, as with any instrument. Dial the ophthalmoscope diopter to 0. Dim the lights so the room is dark, so you're able to see better, and so that there's no external sources that are constricting the pupils of the eye, because you just want to focus on the eye that you're assessing. You're instructing the patient to look at a distant object or focal point over your shoulder, and you're gently placing your non-dominant hand on the patient's forehead or their shoulder to kind of help stabilize them so that they're not moving back and forth or side to side. And what you want to do is you're going to be assessing the patient's left eye with your left eye, right eye with your right eye, all right? So it's same eye to the same eye. You're going to position the ophthalmoscope about 12 inches away, and you're going to be at a 15 degree angle. So you're not looking straight ahead. You're kind of like looking kind of at a 15-degree angle where they are. You're going to look through the aperture with your right eye and direct that light into the patient's right eye. In this example, this picture example, it's the patient's left eye that we're looking at, and the provider is using their left eye. Okay, so it's right to right, left to left. Once you see, you're looking through the aperture, once you see a red reflex, and which is just a redness, it's kind of like when you are taking a picture of someone and you see redness in their eyeballs, that's exactly what you're going to find. You're going to then move closer until you're able to capture the retina and identifying any landmarks of the retina. So again, you'll continue to move towards the pupil and adjust the lens for focus until you're able to see the internal structures. And it takes a lot of practice. The very first thing you should note is the optic disc. And when you note the optic disc, you can follow the blood vessels in and around until you see the rest of the visual field of the retina. So when you're looking at the optic disc should be yellow, orange, or creamy pink, should be round in shape and sharply demarcated. The retina, which is the entire background, should have arteries and veins, and the background should be a reddish-orange coloration. When you're looking, when you're having the patient look into the light source of the ophthalmoscope, you'll notice the macula, and the macula will be a yellow oval shape, and you would just repeat this test on the other side. The optic disc is round, it's defined, the color is creamy yellow. The physiologic cup, which is that indentation in the middle of the optic disc, is also present, but lighter in color. The cup is less than half of the optic disc's diameter, and the retinal arteries should be red. There shouldn't be any cloudiness, there shouldn't be any damage, and they get thinner and thinner as they move away. The veins should be obviously darker, and the background should be a uniform reddish-orange in color. And the macula, once that patient looks right into the light source, should be oval to round shape and darker in coloration. Abnormal findings include cotton wool spots or white patches, and that can be indicative of retinopathy, drusen bodies, as well as papilledema. Papilledema is simply areas of swelling, very lighter red, lighter color of the retina. The Healthy People 2030, as with the communication and auditory goal, sensory and communication disorders goal includes prevention of sensory as well as communication disorders, and communicate with your eyes to improve quality of life. And so one of their objectives is to preserve sight and prevent blindness by reinforcing comprehensive eye exams, nutrition, foods that are rich in vitamin A are very important for the eyes. Really rich colored fruits and vegetables, rich reds, rich oranges, such as carrots, are a great example of vitamin A dense foods. Wearing protective eyewear, especially going out in the sun, preventing ultraviolet light to enter the eyes. And then giving your eyes rest. And then if patients do wear contact lenses, there should be appropriate hygiene that should be taught. And our last question for today, you're assessing the red reflex in the patient's left eye. Where should you position the ophthalmoscope? 10 inches away at a 30-degree angle, 11 inches away at a 15-degree angle, 11 inches at a 30-degree angle, or 12 inches at a 15-degree angle. So we know that it's definitely not 30-degree angle. We said it's 15 degrees, so we can eliminate A and C. And it would be 12 inches at a 15 degree. So the answer is D.